Good morning, everybody, and welcome to the first 2022 Survivorship Lecture Series. Um, this series, for anyone just joining us, is a monthly series lecture that features speakers that are experts in their field of survivorship, affiliated services to cancer survivorship. So I'm very excited this morning to introduce Heather Moky. She is a pelvic health physical therapist at UI Health. She has a master's and doctorate of physical therapy from Shenandoah University in Winchester, Virginia. She's been involved in public health on the local, national, and international levels, being the chair of the physiotherapy committee of the International Continence Society. She also teaches an elective at the PT school at UIC and has taught and lectured for a variety of organizations. She's been at UI Health since 2011 and has developed a very successful pelvic health program at our institution. So I'm excited. I've seen Heather speak before and wonderful talks. So go ahead, Heather, take it away.
Thank you, and good morning, everybody. Thank you for being here. This presentation is for you, and so if you have questions, please just raise your hands. And I hope to start off the year in survivorship series with a bang for everyone. So I'm going to share my screen right now. There we go. Okay. So just to start out, I do work at UIC, and outside of working at UIC, I have no other financial disclosures to report. And just some objectives this morning is just to get you a little more familiar with symptoms and diagnoses that a pelvic health PT can treat and how it applies to cancer survivors, indicate evidence-based pelvic health PT approaches, describe PT management and prevention strategies for cancer patients, identify how to find a pelvic health PT, and any other questions about how we can work together and be multidisciplinary. Okay. Survivorship. So that's why we're all here for, and we know that it's become a very important word. But I think next I'm gonna, one patient told me just recently, and she said, cancer was awful, but to me, this now is harder, and I don't know what to do next. And after that, she started crying, and was like, okay, we can handle this. Let's step back. And, we broke down things and gave her some good resources and gave her a short to-do list to really help her take the next step. But that quote was very impactful to me. And in preparation for, this lecture, I was looking up at what research says about survivorship. And what I'm going to say next should kind of frustrate you and make you a little angry. Survivorship care plans appears feasible, but do not improve survivorship patient-reported outcomes. That is what one research thing I read said, and we're all sitting there like, no, that's wrong. And so it should make you angry, because this is our call to action. We need to get out there and prove. But what I did like this article did say was that they weren't sure why. And they said, it was questions, was it really that survivorship care plans were ineffective, or was it implementation issues, or it was inappropriate research design or comparative effectiveness studies? And a lot of times, and I can tell you, speaking from pelvic health, we're not always comparing apples to apples. So the research doesn't really reflect what we're trying to show. But the point is, when there's research out like this, it should make us angry, and it should give us a call to action so that we do better and we are better. I had a cancer survivor who was living independently. She was happy. She was exercising regularly. She was coming up in for her checkup, no complaints 5 years post. So she thought she was going in for just a simple follow-up with her doctor. Everything seemed really good. Well, then the reality of it is that she had incontinence for years, and it got much, much worse after radiation. She was getting up to go to the bathroom 3 times a night. She felt like she almost had constant leakage. She couldn't make it to the bathroom when she had urge to go. And she didn't want to talk about it because she didn't want another medicine, and she didn't want another monthly bill. And she didn't know she had any options besides medicine. And so how did the doctor find out about this? The doctor ended up just giving her a simple screening tool when she came in, and the doctor went back and actually read the screening tool and talked to the patient about incontinence and explained that there's multiple options for her to treat her incontinence. And this patient was actually really, really excited. And she came for 5 visits of pelvic floor PT. And after 5 visits, it was spread out about 6 weeks. She got up 1 time a night and has even slept through the night. She could delay the urge for 20 minutes, where before, when she had to go to the bathroom, she had to run, drop what she was doing, run right away. Now she had 20 minutes. Her leakage was down 75 to 80% after 2 months. So we can just see, like, obviously this therapy was effective for the patient, but also we really need to talk about the quality of life issues here in the survivorship population here. I mean, from simple therapy, 5 visits, the patient is happier, she is more confident, and she's about 80% better. And she said she would have done it years ago if she knew about it and wish she would have known about it. And she has to continue to work on that last 10 to 20%, but she had a better understanding, she had more education, and it really made a positive impact on her life. And her answer was pelvic floor physical therapy. I didn't know it existed, but actually in reality, pelvic floor physical therapy has been around in the United States, nationally recognized since 1977. And it was originally just started for women to help them in the process of pregnancy, before, during, and after pregnancy. However, the scope has continued to move and expand and include a lot more different diagnoses. And we just see that this is one of our American-based associations through the American Physical Therapy Association. But now there are so many national and international organizations that focus on the pelvis and ways to help patients with a variety of these issues. And the scope has really increased from just dealing with women to dealing to men and children and even transgender patients. And we've gone from just having incontinence and, pregnancy issues to looking at pelvic pain and pelvic floor dysfunction. We look at rehabilitation before and after breast surgery, prostate surgery, transgender surgery, and a variety of other surgeries, even simple hysterectomies. We look and we see patients afterwards. We're able to help with lymphedema. We look at the female athlete. We look at chronic pain. So our scope continues to, to expand, and we treat a lot more than incontinence. We treat urinary and fecal incontinence, pain issues from pelvic pain to rectal. I say, really, from a pelvic floor perspective, we can treat anything between the knees and the belly button. And then we also incorporate the joints outside of there, because ideally everything is connected. We work with interstitial cystitis, the angry bladder syndrome. We talk about painful intercourse and sex issues. We deal with low back pain and SI joint pain. So there's just a variety of things that we continue to expand on here from a pelvic health perspective. But when we look at this, why is this so important? If we look at incontinence prevalence, 12 to 25 million Americans suffer some type of incontinence, and 27.6 of women worldwide have incontinence. If urinary incontinence was a country, it would be the 3rd largest country behind China and India. So when we look at this in different perspectives, we should have to realize what a big impact these issues are having. And when we look at Rasmussen et al., and specifically looking at gynecological cancers, we see that in 550 articles met, and 31 articles were included, that pelvic floor dysfunction are prevalent in gynecological cancer survivors, and it's an important area of clinical concern and future research. So if we are not addressing this as a whole, we're really missing the boat here, unfortunately. And we look and see just before treatment and after treatment in cervical cancers, how you can see stress urinary incontinence. Before, 24 to 29% of people were reporting stress urinary incontinence issues. And afterwards, that number is up to 76%. And what are we doing to help these patients? Because it does come out to quality of life. And you can just see the different issues from fecal incontinence from 6%, it jumps up all the way to 34. I'm not going to go through all the numbers with you, but you can see it's kind of astounding and bothersome. If we look at ovarian cancer and we look at the survivors there, sexual dysfunction affects 62 to 75% of ovarian cancer survivors. When we look at breast cancer, we see how there's so many different things they go through. From the endocrine treatments, they have so many negative side effects that affect quality of life, and also sometimes adherence to therapy. So we need to be talking about these things, educating, and giving options and solutions for how to make these paths easier for patients. I just had a patient who is a 10-year survivor and just got off one of her medications. And she's just telling me how wonderful she feels because her side effects are down. She feels like she's getting her body back, but yet she had cancer over 10 years ago. So we can see the long lasting effects that different types of cancer have for patients. When specifically looking at breast cancer and the different type of side effects, there can be hot flashes, there can be vaginal discharge, dryness, you can have pain in the joints, pain with urination, pain with intercourse. And when we look at the research, prolonged estrogen deprivation may lead to atrophy of the vagina, the vulva, the lower urinary tract, and the supporting pelvic structures. And that causes a lot of weakness and then disuse, and it becomes to quality of life issues. And these results is a variety of symptoms in the pelvis that include incontinence, pain, sexual dysfunction, and other issues. We look at dyspareunia, that's a fancy word meaning pain with intercourse. Say 60% of women experience episodes of pain. And there's a variety of different ways that people experience the pain, from being just going to their doctor to follow up, having an exam, whether it's to identify cancer or after cancer. I mean, I have women tell me how scared they are to go to their doctor after cancer treatments because of the pain they experience. There's other issues like chronic constipation, which we don't think about, but these things can really impact, no pun intended, people's quality of life or their daily ability to do things. And these are questions we should be asking all our patients. We look at different scars from surgeries, and also when you have radiation, that creates scar tissue that can, cause problems in daily functions, from going to the bathroom. There's also myofascial pain. And when we talk about myofascial pain, there's just a study done in 2010 talking about the importance of just looking at the pelvic muscle tenderness and how that can cause chronic pelvic pain. And we need to be identifying these issues more often. So if we think about, and when I'm talking about these things, of course, I start out with looking at some of the bigger topics, and we look at breast cancer and we know the prevalence and how terrible it is, but we also can see it doesn't just affect women, it affects men. So you're on a train and you have an elderly man is waiting for the bathroom on a train. He's next in line. He's getting nervous. He's having a hard time standing. He's unsteady on his feet. He's grabbing his pants, and then what happens? There we go. Do you think he's going to take the train again? Do you think he'll talk to his doctor or nurse about this? Will this limit him wanting to go out and do things? And what can we do to change this? A lot of these things we see with, post-prostatectomy issue and incontinence. If we look at the prevalence of urinary incontinence in men, up to 39% of men will have urinary incontinence and increases with age. 66% of men experience urinary incontinence after prostate cancer. We looked at post-prostatectomy incontinence, it's up to 60%. And the numbers in post-prostatectomy urinary incontinence, they are getting better. And a lot of that is due to, us identifying the problems, better surgical techniques, going to physical therapy, and other advances that are really getting people out. I remember one young man that I worked with, and he was in his 50s, and he had season Bears tickets. And every Sunday during the football season, he wanted to go to the Bears game. And of course, he had to take the year off while he was dealing with his prostate cancer, but he was so excited to go back to, the Bears game. But it became very prohibited for him because he had incontinence and he had urinary urgency. So he said, Heather, I went to the Bears game, but I went to the bathroom 10 times and it just was awful. So he missed most of the game. And literally one of his goals in therapy was just to get him to be able to hold his bladder so he could sit through the Bears game and go back to one of his great joys in life. When we look at conservative management of post-prostatectomy urinary incontinence, systematic review shows based on available evidence, pelvic floor muscle training with or without biofeedback increases the return to continence more than no pelvic floor muscle training in men after urinary incontinence after radical prostatectomy. Said immediate post-operative pelvic floor muscle training increases return to continence. And I mean, I can list more and more of these for you, but the research is out there and we just need to make sure we're connecting people. I don't work in our wheelchair clinic here, and in our department, we offer a lot of different options to help other patients outside of incontinence and pelvic issues that are very prevalent in the survivorship clients. However, but there was a patient across the hall that was being assessed for wheelchair needs, and the treatment area is very close to my room. And there was just a terrible smell in the hallway. And the screening, I went and I talked to the screening therapist for a moment when she was going out to get some tool for her evaluation. And I asked her about urinary incontinence, and she said, oh no, the incontinence screening was negative. The patient says they don't have urinary incontinence. And I said, well, I can smell urine and they're having some type of problem. So I gave the therapist some other questions that she could ask that patient to help to lead to better answers so we can figure out how we can be more effective and efficient in getting the tools our patients needs and the treatment they need. And so a lot of times I tell people you have to ask better questions to get better information. I've been doing this for about, over 20 years now, and I've treated people many times that tell me when I ask them, I said, oh, what are you here for? Oh, well, my doctor sent. I said, oh, are you having any urinary incontinence or leakage? And they say no. And I think of this one particular woman who I treated her. She told me she was wearing pads. She was changing pads because they would get wet, but she refused to admit she was having urinary incontinence. So there's definitely a level in this population of not wanting, after you've just gone through all these problems, after you've just survived cancer didn't kill you. So why should they complain about leakage? Why should they complain that it's harder to have sex with their partner? So a lot of times it's up to us to ask these questions to get them opening up and to identify their needs better. And sometimes people don't even know what they want. Like that first quote I gave you, the patient said, cancer was hard, but right now she's just lost. It's terrible. She doesn't know what to do next. So helping her to make that path for her is really helpful. So, sometimes when we go through the screening questions and they say, do you have any incontinence? First of all, does your population, do they understand what the word incontinence means? Are they understanding correctly? Do we need to make sure that if we have a interpreter, and I know we do a great job of doing those things, but just really defining, and people will adapt. If you ask them if they, go to the bathroom more often, the people learn to adapt to their problem. And so they'll say, oh, well, I don't leak. I just go to the bathroom every 30 minutes. So you think about that, then you're going to the bathroom almost 20 times a day or more. That's not functional. I had a woman who at night, she would set her alarm clock every 2 hours to get up to go to the bathroom because that's how she wouldn't leak. So she told me she didn't have urinary incontinence. So we find ways to adapt, but we need to point out to patients that these aren't, functional, sustainable ways to live, and we're covering up a problem and making more problems. So when we look at normal intake questions, what should we ask? What shouldn't we ask? And sometimes it's hard to ask different questions. Some people say, I don't feel comfortable talking to my patients about sex, or, I'll just ask the basis, and I think this is where we really need to expand a little bit and ask questions that are uncomfortable, because better answers will help you form the best options for your patients. Reframing your questions. A lot of times when I say, do you have incontinence? And people say no, I'll say, well, do you leak any urine or dribble urine when you cough, when you laugh, when you sneeze? Do you get up to go to the bathroom more than one time a night? When I ask that, many people say, oh my gosh, I'm getting up 4 or 5 times a night. And I say, well, how many hours are you sleeping? Oh, I sleep 6 hours. So you think if somebody is sleeping 6 hours and they're getting up 4 or 5 times a night, what is the quality of sleep that patient is having? And we know how important sleep is. I talk to patients. If you had to go to the bathroom right now, how long could you wait? Many people say, I can't wait at all. Well, that creates problems. It creates, people not wanting to go out in public. Think about going to a movie with a friend. And if you can't wait to go to the bathroom, or you're worried about getting to the bathroom from the movie theater, you're just going to say, no, I'm not going to go out. A lot of times people, another thing they do is they'll restrict water intake so that they don't have to go to the bathroom a lot. So it's learning how to reframe some questions to see if they're falling into these patterns. When we talk about sexual function, are you sexually active? People say, oh no. And they kind of will blow off the question sometimes. And then I do a follow-up question and I say, is that by choice, or is there a problem that's preventing you from having sex? Do you want to have sex? And I even asked, do you want to, ask about masturbation? And people look at me like, but usually as I introduce myself, I say, okay, this is how our session's going to go. We're going to talk about this. Then we're going to talk about urine and fecal issues. We're going to talk about your bowels and your bladders, and we're going to talk about sexual activity. So I put it out there, letting them know, and that I am the professional, and it's okay for me to ask these questions too. I had a 28-year-old female breast cancer survivor who was diagnosed to be invasive ductal carcinoma, hormone positive, HER2 positive, positive for lymph, and she was 6 months into her marriage. And she had no kids, but they do desperately want to have kids at some point. And she had some intake forms. She had to fill out intake form every time she had chemo and for her follow-up appointments. So a minimum of 10 times she filled out that she had sexual dysfunction, and she brought it up to her oncologist 2 times. So how many times did her medical team address this with her? None. And can we do better? Will we do better? I hope that, talking about these things, it's not saying anybody did anything wrong, but I think we always need to look about how we can do better and serve our clients. It's when we look at teamwork, coming together is a beginning, keeping together is a process, working together is success. So bringing up these things and working as a team and figuring out, I know healthcare continues to get more and more challenging, and we have less and less time, and we get less and less reimbursement. So we really have to fight for every moment we have with our patient. And we have to look at, what's most important. And so we can't get to everything, but that's where we have to build our team together and make sure as we make this multidisciplinary approach that we have people checking off each aspect of life, from counseling to return to work, to their sexual life, to their personal life, getting physical activity, pharmacology treatments. A lot of these problems can lead to different types of pain. And when we look at the research out there, they say physical therapy is an integral part of chronic pelvic pain that includes a multidisciplinary approach. We can look at the research, and multidisciplinary approaches are very well, supported. And when we look at common, treatment approaches in pelvic health PT, we do everything from pelvic floor muscle training, we do biofeedback, we do education on bladder irritants. We talk about scar care and scar mobilization, scar tissue issues, bowel and bladder retraining, muscle retraining. And we don't just retrain the pelvic floor, because everything is very connected. We look at abdominal muscles, we look at posture, we do with functional integration. We even, people come in and they say, well, this is my job and this is where I'm having problems. And we talk about how to do it. I had a gentleman who was post-prostatectomy incontinence patient who was a handyman, and at work he was having problems because when he would do heavier tasks he would be leaking. So we went into our work conditioning room and started practicing some of those tasks and teaching him how to activate certain muscles so that he could do the task successfully without having the leakage. We talk about lifestyle modifications, core stabilization, electrical stimulation. There's so many tools we have in our tool bag. And we also do a lot of different behavior management and behavioral training. When we look at habit training, we look at the bladder, we look at diet. A lot of times people have constipation issues and they're very simple. They just need to understand how to do the proper combination of water and fiber and putting it together with some activity. Now, I realize my job as a physical therapist, I'm very blessed in the fact that I have more time with my patients than most medical professionals. And I'm lucky that I get the opportunity to do this education. But so much what I do is education and teaching patients how to go home and integrate this into their lives. We talk a lot about pelvic floor muscle exercises, doing the Kegel, as people know, or beyond Kegels. A lot of people think vaginal weights is the answer to everything. And actually, I don't use them at all, but we'll talk about them and I can tell them the pros and cons of them. We talk about dietary training. We have a variety of different modalities that we use, from real-time ultrasound to biofeedback. We have electrical stimulation. We look at our manual techniques. We do trigger point, dry needling, trigger point, myofascial release, visceral manipulation. So a variety of things of what the patient needs and identifying it. So this is another quote from a breast cancer survivor. I brought it up twice with my doctors, but it's not a priority to them. I get it because they're focusing on keeping me alive, but it's a very real part of my life that I have to deal with, and my husband has to deal with it, and nobody wants to talk about it. And so, I mean, that was from just a patient sharing her frustrations. And I like to have these quotes because it makes me try to think about how I can do better and how we can help these different patients. So let's talk about sex. Patients should be advocates for themselves, but doctors shouldn't be afraid to ask questions. And when I say doctors, this is just from a quote from this patient, but it's doctors, it's nurses, it's medical assistants, it's learning how to ask uncomfortable questions in the right way. When people come into me, I have the luxury of more time than some of the doctors or other medical professionals. But we talk about vaginal moisturizers, we talk about lubricants, allowing time for arousal, and how to help them relax. We continue on to talk about a variety of education of self-care, and when there is pain, how they can help learn to take care of it themselves, and stretching and strengthening. We talk about different positions when we're talking about sex, and understanding with lubricants that there are some lubricants that have glycerin in it, and glycerin can be very irritating to these post-cancer tissues. And knowing that instead of buying this type of lubricant, this other type of lubricant could be much more helpful. It's learning to connect the brain to the body when the body has gone through so much trauma of the chemo, of the radiation, of trying to get through this terrible disease that can kill them, and then trying to get back on their feet and making these muscles work in the proper way. We have a variety of modalities we use, everything from using dilators. And this is so important because even if you have a client who's 78 years old or something like that, and you think, well, their husband died, they're not dating, they don't need to worry about sex. Well, we still need to worry about that patient coming in for checkups and having a possible pelvic exam. And if it's painful, then they're going to shy away from those things. So knowing our tools and knowing how to use them are so important. When we do treatment on these post-cancer patients that have sexual dysfunction, there's a variety. There's education, it's teaching them to relax, it's using dilators. Sometimes we do internal and external manual work. The woman I spoke with about earlier, who's 10 years post, who just got off her medication, she was referred to me about 6 months ago. And I've been working with her a little bit on and off due to her work schedule. And 10 years post-cancer, she is a newlywed of 2 years, and sex is an important part of her life, but she's having a lot of pain with it. And right now I can tell you that we have decreased her pain by over 50%. And, on paper, people would say like, is that really good enough? Well, from her trying to have sex with her husband from an 8 out of 10 pain where she didn't really want to do it, to a 4 out of 10 pain where she's like, it's getting better, Heather, and I'm more encouraged. That's huge. But then we go and we talk about other things, like there's a variety of things on the market that if we know about, you can help educate people. And this is called the O-Nut. This is to help decrease painful penetration, to help find a comfortable depth for both cancer survivors and other patients as well. You can use one or multiple. And this is one resource that I gave to this patient, and she was so excited. You thought she just won the lottery. And it's just something she didn't know about that she thinks is going to be very practical and help change her, sex life, especially being, a newlywed of only 2 years. We talk about so many ways to take care of the tissue. We give education, and this is just another organization, the NVA, the National Vulvodynia Association, that gives some great information that I use a lot out. We talk about self-help tips for vulvar skin care afterwards. We go back to our pelvic floor muscle training. A lot of times, as I said, connecting the brain to that pelvic floor is so important. We have different tools out there like biofeedback. This is an example. We can use external sensors with this, or we can use internal sensors. And actually, we were lucky enough just in the past, I would say, year and a half, it was sometime during COVID, that we got a new upgraded system that's really important for us. And we can send these reports to doctors. And I don't know if you see the top, you can see how there's these different peaks and valleys. And you ask the patient to contract, you ask the patient to relax. It teaches the patient to see what their body's doing when sometimes you can't always feel what your body's doing. And teach them how to strengthen the muscles in the right way. You look at the bottom part of the screen here, and that it shows that this patient isn't having other muscles working that we don't want working. So this patient has been able to use the right muscles. And when you look at research, I mean, you just say for a research study that was shown for women who haven't gone through cancer or anything like that, but just to identify the pelvic floor muscles, 30% of women didn't know how to do that. So then if you imagine that you go through a variety of cancer, whether breast cancer or pelvic cancer, you have all these different treatments, identifying those muscles are going to be even harder. Real-time ultrasound is another thing we have here, and we can put it on the belly and look at the bladder and look at the pelvic floor muscles. And it's a valid and reliable source to assess the pelvic floor function. And we can do it in men and women. And so for people who have different histories or do not want to do internal work or something like that, we have these other tools to help work on problems as well. And so like, here's an example of when you put the real-time ultrasound, you can see the bladder here, and then here are the midline pelvic floor structures. And you look at how you make these muscles work at the bottom. So it's actually pretty neat. But the key to life is balance. And it's not just always about the pelvis, but there's so many other things to look at. You need to know your patients. You need to know what are the barriers for your patient. Is it language? Is it education? Is it stress? Is it depression? I have a wonderful gentleman I'm seeing right now who is going through cancer treatments. And he is dealing with very, very bad depression to the point that, we said, let's take a break and, focused on getting him some counseling and working with different medication changes because he was getting too stressed out. We need to figure out how to be more effective for our patients. We need to listen. We need to educate. And I had a professor many years ago who said, Heather, if you just really listen to your patient, they'll tell you what they need. And I realize we deal with a lot of challenges in healthcare. We don't always have the time, but we have to figure out how can we listen better to our patients, and how do we motivate our patients, and how do you hold them accountable too? Because I tell people, I'm not going to work harder than you're working. I need you to put some work in at home too. And sometimes our job is to motivate. The quote at the beginning of the lecture, I talked about this woman, she is just so overwhelmed. She doesn't know what to do next. So if you look at her, it looks like she's being not compliant. And it's not that she's being not compliant. She just doesn't know what to do next. And she's very overwhelmed. And we're helping to give her small task lists that are going to make small changes for her so that she can handle bigger changes. But once again, the multidisciplinary approach, many disorders contribute to chronic pelvic pain, and an integrated multidisciplinary approach to diagnosis and treatment is essential to achieve the greatest success. I mean, there's so much research out there supporting this. I have 0% interest in sex. At the end of all, I feel like I'm a bad partner. I feel like I'm a bad wife, and I resent my condition even more than I already resent cancer. And some of these quotes I didn't necessarily get during treatment sessions. I took extra time to ask some of my cancer patients if I could talk to them kind of outside our session and just ask them a couple other questions so that I could understand better and also, help teach other people what they're saying. So when people are asked specific questions, they'll give you some pretty honest, shocking answers. And we don't always have the time to do that, but we need to keep these in our forefront somehow. And when we look at our post cancer survivorship population, it's really important to realize that they may not have incontinence, they may not have sexual dysfunction, but they may just have problems with balance. May have problems with lymphedema. They may have problems with vestibular issues. A medicine that they're on could cause problems. Depending what type of cancer they had could lead to other issues. And working together as a team, we have so many different things we can offer them from outside of my personal physical therapy area. We do strengthening and stretching and balance issues. We have vestibular here. We have lymphedema. There's so many things. We can refer out to, nutrition and dietary. We can work with, counseling and depression. And we have so many wonderful resources like Wellness House and different lectures that are coming up that really help people slowly get back their life and to help these survivors get back on track and be part of a productive life, that they have quality of life and they're not hiding all these issues or just trying to make it through the day or just feeling really overwhelmed. Here at UIC, we have 4 pelvic health physical therapists that are in the outpatient section. There's Eve Barron, there's myself, Heather Moky, Julie Polton, Anita Schlett Cunningham, and we have so many other fabulous physical therapists here that have a lot of other specialties as well. But I invite any one of you to reach out to me or anybody on my team with questions or concerns or wanting to learn more. Now, I tell people that at the end of the day, I don't care if patients come to me. I just want to make sure they find a really good therapist. And there's lots of ways to do it. I get calls from people in Boston saying, how do I find a good pelvic floor physical therapist? Or one of you will go home tonight and you'll talk to your family member in California and find out that they need help. There's lots of different ways to find pelvic floor physical therapists or other physical therapists that have specialties. You can always reach out to me, and there's my email. You can go through the American Physical Therapy Association. They actually have a Find a Therapist section. If you go into the Women's Health section or the Academy of Pelvic Health section, they have Find a Therapist there. There's a variety of different issues. And I see a question in the chat, which I'll answer in a minute. There's a variety of different organizations that are out there that also will help you find people that have taken certain levels of education. And also too, it sounds simple, but you can even just Google pelvic health physical therapy and you'll start finding a lot more than you did 20 years ago. So it's very encouraging in a lot of ways. So the question in the chat is, do any of you I see pelvic health therapists speak Spanish? And I was going to say poquito. Actually, at this current time, we don't. We'd love to hire somebody that does speak Spanish, but we have many tools to us at our disposal. A lot of times we work very closely with the in-person, interpreters here at UIC. We work with Yesenia, who we book out ahead of time. We have the online language service, the language line. We also have a video language monitor too that we can use. So we always make sure that language isn't an issue. My bias is I love having the in-person interpreters here because I've worked with them long enough that we really gel well and we can identify problems quicker than using the language line or the video interpreting, but we do have lots of options there. The next question on the chat here, and I'll open this up for questions to everybody as well, but do we also see children and down to what age? So yes, we do see children. And So with children, so two of our therapists are trained specifically in children for working with bowel and bladder issues. And I would have to ask down to what age. So we also have a wonderful pediatric department too. And also right now in inpatient, we also have another woman there who does some pelvic health and works with NICU and mother baby. So we have a variety of resources at different levels for different ages to make sure they get to the right person. Another question here is, this is challenging in all aspects of healthcare, but what is the approximate wait time to get into PT at UI Health? So it is challenging. And I would say right now, if you wanted an evaluation with me, I think the wait time is maybe about 5-6 weeks, which that sounds terrible, but I have to point out to you, we do get referrals from other hospitals because right now I think the wait time at Northwestern is 9 to 12 months. I believe the wait time at Rush is I think somebody told me 5 months. So even though it is challenging and frustrating, we do a pretty good job. When we look at our different, I can't speak to all our aspects of how long the wait time is because we have ortho, we have OT, we have hand specialty, we have vestibular. But I would probably say it varies anywhere from 3 to 6 weeks, and I can get a more updated answer on that for you. So, and I'll answer more questions in just a couple minutes here. But just kind of finishing up this, there's lots of ways to find pelvic floor physical therapists. I am one of your resources here at UIC, and I love to talk about what I do. I say I've chosen a weird profession, but it's such a invigorating profession because I love people who feel like there's no help for them. And you go to work in the morning and you may meet your friend Lynn at the water cooler and they ask how you're doing, and you'll say, oh, I got to go in for surgery. I got to have these problems. I have that problem, blah, blah, blah. And, you'll talk about that and somebody will see maybe your arms in a sling. When you have these pelvic health issues, you don't wear a big Band-Aid on your pelvis. You don't have a cast on your pelvis. So a lot of these things you're suffering in silence for. It's creating more anxiety. You go to work. I mean, I just evaled a gentleman on Tuesday who said, oh yeah, I only wear black pants because if I leak, less people will notice. So when you think about that, people are coordinating their outfit to avoid incontinence, like that speaks volumes. And you can't even imagine the quality of life issues it does. So another question is, do you do any lectures at Wellness House for patients? I realize there may be patients listening today. I am involved in different aspects of YAS and with Wellness House. And actually, I believe there is a collaboration we're working on setting up. So thank you, Heather, for this talk and all you do with the patients to improve quality of life. Do you have screening tools you recommend that we can use to identify patients in our cancer survivorship clinic that would benefit from pelvic PT? Yeah, I'm happy to send some stuff over to you, Pam. There's some simple questions that I can give you, 5 questions to put on your intake form that can be red flags for you. We have outcome measures that you can do too. I can send you a couple of those. And yes, Kelly Mitchell wrote back, I don't know if people are reading this or not, but Wellness House is programming specific around pelvic health, both information education as well as yoga focused on pelvic health. So, and yes, Kelly, I'd be happy to do a presentation. I like sharing what I do with people. So let me just kind of finish up here and then I'll just kind of open it up for any more questions if I can get out of my chat. So here we go. So yeah, so just take home messages. Pelvic health therapists treat more than just incontinence. We need to individualize a program for patients and treating the whole person, which I know that's all of our goals. And I know we all face so many barriers. Don't be afraid to ask difficult questions, know your resources and what they can offer your patients, and just a multidisciplinary approach is best. this is a pretty cool quote. And obviously you guys can tell I like quotes, but unity is strength. Where there is teamwork and collaboration, wonderful things can be achieved. And this came, and I actually looked up this person, and it was actually a little kid who actually died from a rare disease at the age of 13. And just to have that insightfulness, before the age of 13 is pretty cool. So I've been blessed to be here at UIC and meet wonderful people, and I continue to work for ways that we can continue to build and raise our bar and offer, better options to our patients. So thank you so much for inviting me today. And I'm just going to open up for any other questions.
Wow,
So-
Heather. The first time I heard this talk was the first time I heard about pelvic physical therapy, and my mind was blown. And it's blown again. That's just so, this is why I love you, is how holistic you are in providing care for these patients, and all the different dimensions that you approach are incredible. And love it, love it, love it, and love connecting you with all these other resources. Wellness House, glad that you're involved in Yes. I know you do so many external speaking engagements.
Thank you.
So really getting the word out there about pelvic PT. And I usually go through the questions in the chat, so there's not a lot, but yes, Dr. Shabai, I've heard it before too. And it's really a fantastic lecture. Betty says she learned so much. Do we have any other questions from anyone? Oh, Talia.
Question.
Yeah.
Right. Hi, Heather. Thank you so much for your presentation. You're such a rock star.
Yeah.
As you were talking, I couldn't help but think about young women diagnosed with breast cancer or young women living with metastatic disease. Can you talk a little bit more about why it's important for healthcare providers to talk to young women about sexual health, and how to initiate that conversation, and possibly when's the right time to start that conversation?
Oh, you're asking me some tough questions, because I'm going to answer your question to the best of my ability, but also we have to realize that it's going to change for every person, and I just think it sounds silly, but, I think, first of all, you yourself as the medical practitioner just have to be fair. Do you feel comfortable asking a patient, are you sexually active? And if you're not, are you comfortable asking a patient, do you masturbate? Are you able to achieve orgasm? So in some of these words, I laugh and say that, if my grandmother knew I was saying these words, she would probably pull me out of this presentation right now, because that's how I was raised. You don't talk about that stuff. But we need to talk about that stuff. And it starts by you and feeling how you feel comfortable with it. And also to, in this day and age, understanding that, what does sex mean? Sex isn't always, a penis penetrating a vagina. And it's understanding that and feeling comfortable with asking about other types of sex. I work a lot with the transgender population, and I'll say, who is your preferred partner, and what does sex look like for you? What are your challenges? Are you having pain? A lot of times when people are having difficulty with sex, they shut it down. And then if they are brave enough to mark it on a paperwork somewhere, and we don't follow up with them, they feel like, oh, they don't care about my sex life. So, and sometimes just saying hey, you're in this journey, and I know you got a lot going on, but, your sexual health and your sexual intimacy, whether that be with yourself or somebody else, is really important. And we're going to put that on the list to talk about. We don't have to talk about it today, but do you have a partner right now? Do you have concerns? And sometimes people at first, they're like, no. And I can say, okay, well, it's not a concern for today, but I'm going to put it on the list to follow up again in our next 2 or 3 visits, and then get out a sexual dysfunction outcome measure, or have them fill out a form to ask some questions, and just say sex, right now, it is expected that sex is going to probably be painful. And there's a lot of things we can do to make it not painful. So it starts just by education, and identifying, and also making sure you feel comfortable asking the questions. I remember many, many years ago, I had a gentleman who was homosexual. He wasn't in a relationship, but he was telling me he was having sexual dysfunction, but really wasn't giving me any information. And I just thought that I'm like, okay, how do I word this correctly? And literally I went home that night and like wrote out different ways to ask questions about masturbation, different, so that because I was like, oh, that sounds terrible, Heather, don't ask it that way. But I took the opportunity. I felt something that I felt uncomfortable with and figured out how to make it not comfortable or make it less uncomfortable, make it comfortable. So, and some people, my my one woman from the quote at the beginning, she is so overwhelmed, sex is nowhere on her radar, but she's still at an age that, she could and she would and she may, but also she has a colostomy and she's scared and like even talking about those things. I have handouts about different positions, about, which way has deeper penetration, which has lighter penetration. I give those out all the time, so there's lots of options. And it's just really getting to know your patient and feeling comfortable with questions. And, there's times that in any evaluation I do, I ask about sex, I ask about history of rape or trauma. And a lot of times people shut me down on a lot of those things. And then further in sessions on, they said, oh, hey, you asked me about this before and I thought about it. And so once they get to trust you more, they sometimes will open up. And otherwise you just, if they keep shutting you down, just say, there are lots of options out there. We have different therapists you could work with. There's sex therapists, there's physical therapists. So we can approach anything. So if you feel at some point you want to talk more about this, I am here. Here's my email, and I do get people reaching out. And even I had one woman like 3 years, she's like, I saw you years ago for this and this, and now I'm having this problem. Can you help me? And I wrote back, gave her, and then she ended up coming back in for some therapy and we addressed those issues of dyspareunia. So there's no right answer, but at least trying to ask, trying to get some information, you're on the right track. And if you want to just ever talk about sex and ask those goofy questions, let's have lunch together.
Awesome. Thank you.
Yeah. Other questions I can answer or?
Hi, quick question. First of all, thank you. This was an awesome presentation. I think it's really helpful for all providers, including primary care providers, which is what I do. So I think a lot of us don't know all the resources that are out there. So I think it was wonderful to hear. So thank you so much. My question for you is that, there's a lot of patients who, in terms of physical therapy, any kind of PT, it's sometimes challenging for them to get to appointments once a week. Do you guys offer and this might be challenging to do physical therapy, but do you guys offer any video visits, or do you have any resources if patients just want to, try some exercises at home? Are there any kind of resources that you might recommend?
Great question. Thank you for bringing that up. And I think that, in the midst of a pandemic, that's one of the things that we've really upped our game on. And that has been a positive thing that come out of the pandemic is offering telehealth visits. So yes, we do telehealth visits here. We are equipped to do that. It's kind of a variety of it. So depending on the patient's needs, I've done all telehealth visits. I had a cancer survivor who also had terrible anxiety. So for her, telehealth visit was so important. And we made great strides. And we got to a certain point and I said, well, we were probably about 70% better. She learned how to do her urgency, handle urgency better. And, then at that point I said, you can continue on this way. At some point I'd like to see you in the clinic, but if it's not an option, I've worked with people who are 3 hours away and can't come up here, and we do telehealth. So, a little education or some education is better than no education, and so we do have those resources to do telehealth.
Awesome. Thank you so much.
You're welcome.
I'm sure there are more questions. If you have any other questions, you can forward them to me or directly to Heather. Her email's on the screen. Last one, really quick. Dr. Javine, can you recommend any sexual function questionnaires that we can use in the office? Are there any that are validated?
Yeah. So quickly, like, then we want to divide it down for male or female. And also, you have to be careful too, when looking into transgender, because we want to make sure to respect those patients too. The shim is a great one for male. And I'm going to grab my book real quick so I make sure I say the name right. And if you want some, actually, I can scan you a couple of the things I have.
That would be great.
Yeah, if you want, we can do that. And so, but also too, you don't always need the outcome measures. Sometimes just some of the questions of, do you have, are you sexually active? If you're not sexually active, is pain or another problem restricting? I mean, it was funny, but not funny. But one time I met a woman who had a total hip replacement, and she was so angry that her orthopedic did not ask her if she was having sex. And when she brought up having sex to him, she was kind of blown off. She's like, what? Does he think just because, I'm older that I'm not going to be sexually active? So just even asking those questions is a good start. And if they're having problems, but I was going to say I'm trying to find it right here. I think it's the PISC 12, but so there's one, pelvic organ prolapse, urinary incontinence, and sexual function questionnaire. That's one, but I think really if you just start with basic questions, that would be more effective. But please email me and I can help, give you whatever resources I have. So my email's on the screen.
If you could forward those on to me, I'll post them in the folder with this talk recording and your slides, forward them to me kindly, Heather.
Great.
So thank you so much, Heather. Great presentations, just wonderful information for everyone. So with that, let's all get on with our mornings and way to kick off 2022. Return next month.
Thank you.
Thank you.
Thank you for having me. Pleasure.